Thank you so much, Mary. I'll pass it over and let Dr. Diamond share some of his insight next.
Sure. I'm gonna be a little bit more dry. I'm gonna just provide a little bit of disease overview, maybe putting some of what Barry said into context. I'm gonna share slides if that's okay. Can you guys see that? Does that work?
Yes, thank
Yes.
you.
Okay. So I'm a neurologist and I have an appointment in two departments. I'm in the Department of Neurology primarily, and then also I'm in our medicine department in the group that does what's called early drug development. So early phase trials of drugs that are sort of newly being investigated. Sorry. There. So I had a windy background to be doing this field. So I first studied religion in college, and then I actually went to graduate school in history of science before I went to medical school. Then I studied medicine, and then I studied neurology, and then I was pretty much prepared to do only brain tumors. That's my training. And then when I was a trainee, I diagnosed an ECD patient in 2011, and that just sort of captured my interest. And I diagnosed two other people with ECD in those coming few months. And when I became faculty in 2013, there was a clinical trial of vemurafenib, so not the exact treatment that Barry's getting, but a sort of a sibling, very similar treatment. And so in the last 12 years, I've run two clinical trials for medications that have subsequently been approved for ECD. And I think over my 12 years, I've seen about 250 ECD patients, something like that. And at this point, at least 90% of my clinical practice is ECD and other histiocytosis. And then just from a personal point of view, I live in Brooklyn with my husband and my twins, who are now almost 9 years old, which is not close enough to 18 because I want them out of my house. But anyway, we're almost halfway there. So some background on ECD. So it was named after these two physicians. So Jacob Erdheim was in Austria, and William Chester was his American medical student. And they had a patient who unfortunately died, and they did a very detailed autopsy. And they sort of made a very, this is Jacob Erdheim in the picture, they made a very detailed characterization of this one patient, which ultimately was sort of the first case of ECD, and it's named after Erdheim and Chester. And it's a disease that affects multiple body systems. And then the main two sort of sources of health problems are the fact that the disease sort of takes up space, it causes tumors, it infiltrates tissues, and then it also causes generalized inflammation throughout the body. And I would say that EC is kind of like a cousin of LCH, and that the abnormality is in the same sort of area of the blood cell family, but it's kind of like a cousin, not the exact same cell, but sort of a close relative. ECD affects primarily adults, pretty much 40 and up. The average age is in the 50s. There is such a thing as childhood ECD, but it's extremely rare. People can have ECD in addition to Langerhans or Rosai-Dorfman. They can have what's called a mixed or an overlap form. There really isn't any clear cause that is related to infection or exposure or environment that anyone has ever been aware of or family history. There certainly are instances where someone's ECD kind of emerged after another health event, like an infection or COVID or a vaccine or something like that. And in those rare instances, it's very hard to deny that it happened right after, but no one can really make a link to those things. There's some ideas that I could put out there, but there isn't really a clear tie to any sort of exposure or prior event. And then what happens in ECD is that the blood cells have a genetic mutation. And by genetic, we use the word somatic, which means that it's not inherited, it doesn't pass from parent to kid. They're not in all the cells in the body, they're just acquired just in those blood cells. So that's what I mean when I say genetic. And this is just a description of what those gene mutations are. So this pie chart just shows the distribution of things. So about half of the pie is BRAF, which means that half of ECD patients have this BRAF mutation like Barry does. And then the next biggest chunk is this gene called MAP2K1. And then it kind of becomes smaller and smaller pieces of the pie over here. But almost all of these are in what's called the MAP kinase pathway or the MEK pathway, and they're sensitive to either BRAF inhibitors or MEK inhibitors. So while there are lots of different mutations, half are BRAF, and then the rest are kind of in the same family. There are a small number that are in a different gene pathway entirely, and those can be detected by testing, but those are definitely in the small minority. So this is a bunch of body pictures from scans and stuff like that, just showing that ECD can affect any organ in the body. I'm going to show some of these specific examples in different slides, but as I said, the way that people become sick is either from tumor invasion, like Barry had with his eye, or symptoms of the whole body, like pain, fatigue. Some people have sweats, and some people even have things like just depression and anxiety because their body is so inflamed. So the typical location is the bone. So this here, it looks like a projection of a person. This is a scan where the image has been sort of manipulated to present their whole body, sort of upright. And you can see that this is the legs, and this black here in the legs, that's not supposed to be there. So this is the ECD sort of collecting in the legs. And if you look, looks like you're looking at someone's thigh bone or shin bone sort of face on. And these specks here, these are the ECD in the bone, and this is what it looks like under the microscope. So the classic location of the legs, it can really be anywhere in any bones, but Langerhans generally affects the bones in the midline, like the spine, the hips, the shoulder blade, whereas ECD tends to be further out, in the arms and the legs. So bone pain is a really common symptom, that sort of aching pain in the legs. But I can tell you that the pain doesn't really map on to where the tumors are. So some people have tons of bone pain and you don't really see much on their scans. And some people, their bones are chock full of ECD and they have no pain whatsoever. So there isn't really a one-to-one connection between pain and what bones are affected. In terms of the eyes, Barry, this isn't you, but it could have been you. This is like if someone this is like the person as a hot dog, and I cut the hot dog and I'm looking at the circle. So this is sort of looking at a cross section, and this is the person's eyes, and this is a big tumor sitting behind their eye. So this is ECD behind the eye. It can cause bulging, double or blurred vision, pain and fullness. Some people have ECD in their sinuses, and sort of it seems like they have a quote unquote chronic sinusitis, which ultimately ends up being a disease manifestation. And then ECD can also affect the jaw. And many ECD patients, after they're diagnosed, in retrospect, had all of these chronic dental problems, teeth migrating, falling out, having all of these long-standing dental problems because the underlying bone is not stable in the first place. But that may have been a very, very long-standing history before the ECD diagnosis. About 1/3 of ECD patients have some sort of involvement of the brain, whether it's in the brain, outside of the brain, next to the brain, sort of somehow touching neurologic structures. These are a bunch of different MRI pictures showing those different areas. The most troublesome area is when ECD affects the back of the brain, called the cerebellum or the brainstem, which is what controls movement and balance. So people can have speech problems, balance problems. When there's involvement of the pituitary or the pituitary stalk, there can be that diabetes insipidus, or what's now called ABP deficiency, where your brain doesn't make the hormone that tells your kidneys to hold on to water. So people just sort of drink and pee, drink and pee, drink and pee continuously. And then that part of the brain also makes other hormones. So some people have other hormone deficiencies, some people don't. And then people have varying types of trouble with thinking and memory in some cases. This remains really the most difficult to treat aspect, and it can be misdiagnosed, especially in some patients, as things like MS, multiple sclerosis, or other inflammatory disorders in the brain. And so sometimes patients come to us having been thought to have MS, treated for other things, and then only when treatment for another type of immune problem or brain tumor didn't work does someone kind of put the whole picture together and then end up giving them a diagnosis of ECD. Some other researchers have measured what are cytokines, which is the signals in the body which tell your immune system to turn on and off. They've measured these in the blood of ECD patients, and there's a whole number of these cytokines that are just profoundly elevated, kind of like ECD patients are walking around with the flu all the time, that their bodies are telling their immune systems to turn on. And so I think this may be one of the reasons for the profound symptoms, because people's bodies are sort of essentially tricked into thinking that they're fighting an infection all the time, and that's how they feel. At MSK, we developed sort of an ECD specific symptom survey, which can put sort of a percentage in numbers on people's symptoms. And so they're color coded by the category of symptom. And then what this shows here is what the distribution of people's worst symptom is. So for example, here in 50 people, 48% of people's worst symptom was neurologic or psychologic. And then about 1/3 was some kind of generalized symptom. So there's a predominance of neurologic, psychological, and generalized symptoms. And then this also showed that there's a great deal of fatigue and pain. And this paper, or the existence of this data, has been helpful in many instances for disability, justifying that someone can't work because fatigue and pain don't usually meet criteria for disability because, someone, it's like, can they lift 10 pounds? Can they walk 2 blocks? The typical criteria don't apply. But if we can show with data that this is a disease-related symptom and it's disabling and people can't work, that can justify benefits in many cases. ECD can affect the heart in a few different ways, either within the heart or the lining of the heart, or this is sort of looking at someone head on, and this is their aorta. This is the big blood vessel that comes out, and this gray over here is sort of like ECD lining the aorta. So people can have issues with heart rhythm or problems with their heart function. And that is one not super common, but that can happen with ECD. Also, ECD can involve the skin. It can look like these sort of chunky deposits, or some people just have a smooth, hot rash over their whole body. But if you biopsy that, it looks like ECD. They don't look like, the Langerhans is more scaly and red and irritated. These don't often hurt very much. And then this can be one of the missed footprints of the disease around the eye. Sometimes someone will have a very long road to ECD, and I see them for the first time, and I look at their eyes and I say, how long have your eyes been like that? And they say, well, it's been 3 or 4 years. So this is the kind of thing that can happen in people who don't have ECD, who have very severely elevated cholesterol, because the cholesterol sort of deposits around the eye. But this is just sort of one sometimes hint to underlying ECD. ECD can also affect a lot of the different structures around the kidney, causing different kinds of issues with kidney function. This is just a bunch of pictures of that. So because there's so many different ways that ECD can present, it's always a challenge to diagnose. So it's almost like someone has to have thought about it first, or they have to recognize it, or they have to know that if you see A, B, and C, you have to look for D. And so when I do teaching sessions to general medical doctors or oncologists, I tell them if someone has DI with bone pain, you should think about ECD. Or if they have some strange findings around the kidneys, or if they have these chunks around their eyes, or one of these things and they have issues with speech and balance. Let's say someone got a pacemaker 15 years ago and no one knows why. Maybe that was an ECD manifestation from a long time ago, bone pain in the legs without another reason. So trying to get people to realize that there are these constellation of patterns that should make someone think of ECD. Some other challenges is that many providers, they just don't have it in their catalog to order a PET scan. That's just not in their practice because that's what oncologists do, but that's really sort of the most important diagnostic tests. And of course, a lot of really smart, well-intended people have just never heard of it because it's just so rare. It doesn't fall into one organ or set of symptoms, so it can really present in an unlimited number of ways. And the result of this is that from first symptom to diagnosis can be upwards of 2, 3, 4, even more years. So that's kind of, I just think, the price paid for the rarity and how differently ECD can present. This is from guidelines that we wrote. So this is the whole list of tests you do for a newly diagnosed person, from the things you're supposed to ask about, look for on exam, other doctors to get involved, imaging studies and lab tests. But the backbone of it is the PET scan and the MRI of the brain. And then here, this is talking about the genetic testing for BRAF and other mutations. But this is published, and the idea is that someone who has a new ECD patient has this in front of them as a roadmap to how they can evaluate someone. In terms of treatment, some patients need no treatment. This was not the idea even 10 years ago, but people get scans for various reasons. And I have many patients now whose ECD was diagnosed completely by accident, and they have no symptoms at all, and they really don't need to be treated. And they get scans from time to time, and they're fine. In the past, what I call the conventional, as opposed to the targeted treatments, those were medication called interferon or various medications to suppress the immune system or chemotherapies. They were used more commonly in the past. Now, really, the backbone of treatment is the BRAF and the MEK inhibitors. And for patients with the BRAF mutation, we use the BRAF inhibitors. For patients sometimes with or without the BRAF mutation, we use the MEK. And then some people use a combination, and you sort of land on what's best for each particular person. How to dose people is really like the nuanced, very complicated, critical question, because some people take too little, some people take too much, and what's too little and too much for one person is not the same as it is for another. The conventional treatments, they're pretty much reserved for special circumstances now where the targeted treatments can't be used, or they can't be tolerated, or there's some other reason. Or in other sort of resource-limited environments outside of the US where these targeted treatments are not available, people still rely on these more conventional treatments. In terms of how long are people treated, so I would say almost everyone who needs treatment in the first place is treated forever. for the rest of their lives. Especially patients with the BRAF mutation, the experience is that if you stop the treatment, at some point they're going to relapse. So some people come on, come off, they want a break, they take 3 months off, they go back on. It's really kind of like the long view. Are some instances of people who are treated for a year or two, they stop and it never comes back. They're not many. It's not an abundance. That's not the majority, but it has happened. And I do have people who seem like they're cured from their 1 or 2 years of treatment. For most people, the challenge is at a treatment plan that sort of balance between minimizing disease symptoms on the one hand and side effects on the other. And that's kind of part of it that you have a lot of experience with now the years. I told you about the symptom scale, and then I just wanted to point out some other, I think maybe sort of patient-centered, underappreciated features of the disease that have come from our studied fatigue and pain, and what we found is that in my registry, 3/4 report moderate or severe fatigue, moderate or severe pain, and then almost half report both. One thing that's interesting just from the data analysis is that they're very tied to each other. It seems like, Barry, not necessarily for you, but at a group level, if having fatigue and having pain and their severity are very associated with one another. And to me, as someone who doesn't experience either, that's not intuitive to me that if you have pain, you're going to have fatigue or vice versa. But that seems to be the case, that there's something kind of exhausting in and of itself about having unmanaged pain. And that's something that sort of patients have taught us when we've asked the question. Looked at quality of life. So there's this called the FACT, which overall quality of life for patients with cancer. And so, what it yields is a score that I think goes up to maybe like something like that, 100, 110. And so in the patients, the average score is 71 to 75. And just you make a comparison, if in studies of people with advanced ovarian cancer, their overall quality of life is better than your sort of person with ECD. And then this is someone with non-Hodgkin's lymphoma, the average is higher. And then someone who is 60 with leukemia and has gone through a transplant, on average, their quality of life is better than someone with ECD. So I think, Barry, you're doing terrific, and I wouldn't want it any other way, but there's a lot of challenges that many ECD patients face with regards to quality of life. And just something to realize that even patients with all kinds of other cancers and heavy treatments, on average, even report a better quality of life than your average ECD patient. So it's something to make note of. Then we've also studied frequency of anxiety and depression in our patients, and we've published this. And if you look at adults generally, 1 in 3 have either anxiety or depression. And then 1 in 7 have either moderate or severe anxiety or depression. And then if you look at factors that have to do with that, ECD itself is more associated with depression, having involvement of the brain, strain or unemployment, then having worse fatigue or pain or worse symptom severity is associated with depression. And then just in and of itself, people who had a longer period of undiagnosed illness are more likely to have depression. So I just think that's a lot to take in. And then there's other factors that are associated with anxiety. So in response to the topic of, I just wanted to share a little bit of data about what's known about any sort of disparities in outcomes in diagnosis and treatment. There is very little that is sort of proven. This is actually something that my group is, and I have a trainee who has a grant to be looking at a topic, but ECD is rare. You would imagine to yourself that it is missed or diagnosed late in settings where there are fewer resources, where someone has less access to medical care. So we have early results of a study. Is this measure called the area deprivation index. And basically you put in a zip code and it's a proxy for resources. So it's a geographic measure of local resources. It has been sort of called a proxy for socioeconomic status, which is kind of true, but it's really geographic resources is what it measures. And so what we found is that in more resource limited areas, people are much older when they're diagnosed with histiocytosis, many years. So it does seem like are diagnosed younger in areas where there are greater resources. And then the diagnostic delay, the time from presentation to diagnosis, is longer in resource limited areas. And then something that was surprising is that the time from diagnosis to treatment is actually shorter in areas with limited resources. And on the one hand, that's surprising, but I think on the other, I think that maybe what that accounts for is that when someone has more experience, they may be more likely to know that someone doesn't have to be treated. So I think that a more experienced provider may know that someone can be observed whereas a less experienced provider may jump to treat someone, perhaps not necessarily. And then if you look at why patients are much more likely to have a diagnostic delay of 1 year or more. So I think that this is sort of a beginning of a story that we're trying to look at in our own research. And then you think the one barrier to optimal care can be just the fact that not everyone can travel across the country to see specialized providers. That's kind of the substance of my talk. I think that from an optimistic point of view, I think we've never known more about this disease than we know right now. Are two FDA-approved treatments, and we're in an era of very close collaboration among all of us who focus on ECD. We play very nicely in the sandbox with each other, share our toys, and all working together very nicely. And you hope that in the future there'll be opportunities for all of us to work together and get support for more collaborative research in this area. And that's it. I'm happy to take some questions.